about tobacco and its causes of illness and lung disease, and now we know that compromised air and water is part of how we live, and this is true throughout the world. How are we going to change that? It affects health. New disease vectors. That changes practically daily, and I'll talk more about that. Personalized medicine is the hope for the future. We're in a transition phase now. We really don't know where we're going, but we know the answer is going to be there. And also new systems for access and dissemination of information. These are things that are changing the health world as I know it. You know, being a child of the 60s in the US, I saw the world in one way, but new things have changed it. If we look at the world and we see the life expectancy at birth, this is, and I have the sources all on the bottom, this is what we see. People are getting older. We also see a worldwide trend in people getting older, over 65. We can also look at different parts of the world and see that depending on where you are, you have more and more people who are over 65 years of age. If we look at the older adult support ratio, we can see that Europe, North America, and Oceania, which is Australia, New Zealand, those areas, have major problems. This is the number of young people needed to support an older person. How many there actually will be, as opposed to how many we need. Okay, world aging trends. Now, that picture to me is very much of a myth because, in fact, for many people, that's not going to be their retirement picture. They may think about it, but that's not going to be it. And in reality, while some have spoken about raising the age of retirement past 65, that depends on what kind of work you do. If you've been doing physical manual labor, it's very hard to talk about raising the retirement age for those people. And they get to a point when they just want to rest. They figure they've worked hard and they just want to garden in their own house. Some other world aging trends is about 2/3 of older people living in the developing world. By 2025, it'll be 75%. And the fastest growing group of all populations is a group above 80. And this is a very important statistic to keep in mind because if we're talking about aging, one of the major impacts of being above 80 is the impact of Alzheimer's in people's life. Now, about women. In practically all society, women outlive men. Now, that's true. But for the people over 80, it's nearly 2 to 1. Now, when I'm talking to women and people go, well, what do you do? I said, hey, very simple, marry a younger man. That way you'll always have a partner. Because in fact, what we know that one of the most important things about older people is having an active sexual life. And we have learned that in the past, people thought that people over 65 did not have an active sex life, but when ARP redid their analyses, they found that they had forgotten to account for people who have a partner. And if you have a partner, even if you're over 65, you're still having sexual activity at least once or twice a week, which is more than many of my workaholic friends do, who are much younger. So, workforce and aging. Another factor that, this was from the UN, and it sort of surprised us that they came up with these data that in Europe, there needs to be a net flow of 13 million immigrants per year for the next 50 years, just to offset the working age population. And of course, that the impacts of aging on the labor force requires new approaches that allow older adults, particularly in developed countries, to participate in the labor force, if they want to. In the US, there was a move to have older adults take care of young kids, like in kindergartens and things like that. And then some of the older adults, when you actually talked to them, said they didn't want to do that. They felt they had done it, they were older, they didn't want to do that anymore. So we have to be able to make sure that we ask people what they want. Now, if you look at health spending for older adults, this is what you see for people throughout, what happens throughout the world. Now, you look at the US and you see 5 times the rate of spending for people 65 to 69 as opposed to people 50 to 64. This is very easy to explain, and the reason is in the United States, when you're 65, you become part of the Medicare program, and the government does spend money on you. Before that, if you're between 50 and 64, it's minimal expenditures. So it's 5 times the rate because before there is no national program for anyone. But I'll talk more about Medicaid. So the U.S. aging boom, I like this. It's a couple. They're happy. We like to see that because people who are coupled or in units actually live longer lives and they stay healthier and more active. What we also know is that the 76 million baby boomers who were born between 46 and 64 will start to collect Medicare and be part of Medicare in 2011. That's right around the corner. And those baby boomers are very different consumers than their parents were. We also know if you look at the growth of the U.S. population in ages 65 and over, you can see a trend that goes clearly up. And if you look at the U.S. population composition, you also see another trend. You see the growth of the Hispanic population. And you see the African American population staying about the same, the Asian American population growing, American Indian stays at about 1%, and the non-Hispanic white population being reduced as a portion of the whole population. So as you think of the future, these are important things to keep in mind. The other thing to keep in mind is that if you look at within groups, you know, in the U.S., for example, I never use the word minority. It doesn't help anyone, it doesn't describe anyone. It really is a disempowering term, but I look at what's going on within each group. Because as we look at groups, smaller and smaller groups, we'll get closer to that individual. And really, health is going to be about the individual and what happens with you and your biology and your chemistry and your triggers. But if you look at this, what you see is the fact that there are going to be many more Hispanics who are older than non-Hispanic black elderly. And this is something people didn't understand because they always assumed it would be the same. If you look at insurance status in the US, what you find is that Hispanics tend to be the least insured. And the reason is because Hispanics tend to be the working poor. When janitors for justice in the US were going on strike to have higher wages, they were going on strike to get wages to get up to the poverty line, okay? So these are people who are working, but because they work, they don't qualify for many public programs, but they earn too little to buy private health insurance. And here is the percentage of population uninsured by Hispanic subgroup, and you can see that there is great diversity among the groups. But the message is that Hispanics tend to be uninsured. Now, average life expectancy in years. These data have been pretty consistent for, I'd say, about 8 or 9 years. And basically what it shows is that Hispanics live longer than non-Hispanic whites. You have no idea how much controversy these data created in the US. When I first presented it, people who make their careers on what I call a poverty model of everything were shocked and actually wrote to my board and said I should be fired for saying this because they wanted to believe that if you were Hispanic that you had to be dying because surely as a minority you would have all these health problems. Well, that wasn't true. We do know we have some chronic health problems in the US. I talk about diabetes. What's the important thing about diabetes? Diabetes is a long disease, it's chronic and can be managed. It doesn't kill you necessarily, but it does very much can limit the quality of your life. All right, this is, you've heard a lot about overweight and the problems in the US. When the Centers for Disease Control actually looked at their data, what they found was, you know, overweight was actually not bad at all is what they thought, but they were surprised that if you were overweight, you actually did better than normal weights. Obese was, you know, you started to lose people, but it was when you were extremely obese and then morbidly obese, which is over 40% of BMI, that we have great health problems. So part of it is that if we're going to do things to change people's behavior, we have to deal with those other people and how we work with them and train them. Now the other thing, which is another chronic illness that costs money, depression. Depression is pronounced in the US. We have to work with people. These are people who have moderate to severe symptoms. And you can see it's pretty high. Now, interestingly enough, there's a mythology that immigrants are more depressed. Actually, immigrants tended to have better mental health than the first generation of U.S. born.
Can you just go back one slide?
Sure. To that one? Yeah. You can all have copies of it. I'm going through this fast because I'm trying to, be good here. It's not my nature to be good, but I'm struggling with it. Okay, so here is what we have about immigrants and U.S. born. This was also the person who wrote this, who did this study in the archives of general psychiatry. This was a study that created a lot of, how can I say it, discussion. It's been replicated many times, the idea that the immigrant comes over with some good things, but over time they lose it. And we know this from looking at Hispanics and other groups, that the immigrant comes over with even good health habits, but as they adapt to American lifestyle, which is more sedentary, less eating healthy foods, less family-oriented, all this stuff, people start to lose their good health habits. Now, increasing age is the greatest risk factor for Alzheimer's. And the prevalence doubles every year beyond the age of 65. So we can talk about longevity, we have to know what that means. And according to the National Institute on Aging, which is part of our National Institutes of Health, over half of those over 85 are affected. Okay, and as one of my friends said to me, great, we live long and suffer. The other thing to think about is that the interesting thing about people with Alzheimer's, though they seem to, although they don't live as long as people with dementia, it's more of a chronic illness. Has tremendous costs in health. But where there's cost, there's always opportunity. Now, if we also look, here's more data on diabetes, and as you can see, what's the biggest predictor of getting diabetes is getting older. As someone said, well, what's the best way to reduce risk factors? I said, you can die young. I mean, it's because really the major risk factors for most things is getting older. So we have to take care of the bodies that we have so that science can catch up with us and take care of us then. Now, some interesting correlations we find is that depression and Alzheimer's seems to go together. We also have a relationship between diabetes and Alzheimer's. So in the U.S., a lot of Americans always complain about how we don't have national health insurance. We want to be like these other countries, blah, blah, blah. We actually do. We have Medicare, which was founded in 1965 as part of Lyndon Johnson's Great Society programs. The people who designed that program tell me that their idea was to first get the older people on because they voted, and then we were going to have something called kiddie care for kids. I can tell you we still don't have kiddie care. We're still struggling to even get something close to it. But Medicare is something that we have, and unlike any other program, it's for people over 65. It doesn't have an income test to get into it. You just have to be over 65. You have to be a U.S. citizen or permanent resident with 5 continuous years and an individual, and be an individual or spouse who worked for at least 10 years in Medicare-covered employment. So most people are covered under Medicare who are over 65 or who have, this is a disability. This is the growth of Medicare. And these are in millions of dollars. So right now, in 2005, we were $342 billion. All right? The benefits have really changed. Just a few years ago, in 2004, we included medicines as part of Medicare benefits. Can you believe that? All these years, we had a Medicare program to help older adults, and medicines were not included. Not only weren't medicines included, but any preventive screening was not including it. Now they are part of what we do in Medicare. Now, this is an interesting picture. Both sides go to 2030. One is the number of beneficiaries. You see that going up. And going down is the number of workers per beneficiary. Medicaid. Medicare is a federal program. We have a mess called the Medicaid program. And it's a mess because while it's a federal program which has broad guidelines, the states, each of the 50 states makes up their own requirements. So for example, depending on where you live, you may or may not qualify, and the qualifications may be different. And these are for families who are, it was meant for families and for pregnant women and children. And what we have found over time is that it really has grown, but not as much. It's only $182 billion. And if you look at them together, you can see the difference. This combined, the blue is Medicare, the purple, whatever it looks like, is Medicaid. U.S. and long-term care. If you want to talk about the greatest growth industry in the U.S., long-term care is a growth industry. 12% of all Medicare expenditures is for long-term care. And 62% of long-term care is paid for by public sources. Now, if you look at spending growth and what is anticipated, this is what we see for the future, assuming the world as it is. Medicaid is the largest funding source for long-term care. Now, Medicaid, in order to get on Medicaid, you have to be a low-income person. So getting your long-term care paid for through Medicaid is very difficult if you have any asset. And you just can't sell your asset because the government became wise that some people were, before they became eligible for long-term care, would give their assets to their kids. Now what the government looks back for 5 years to make sure that you didn't divest of what you had. Okay, U.S. and immigration. Moving on. This is our foreign-born population by world region of birth. My situation is very unique. I'm a Cuban American. My family came over before Fidel, and my memories of being Cuban were when I went back to Cuba when I was 5 for a visit. They called me the American, and then later on in my life, during the Cuban Missile Crisis, I was sent out of my classroom every time they said the Pledge of Allegiance because they said I was a Cuban. So I was like, well, this is interesting. But it was one of those things where, as a country, we're not where we really should be. This is by age, US-born, foreign-born, percentage of foreign-born over 65. Most of them are from the Caribbean. Estimates of the U.S. Hispanic population. I say this because there's 47 million people in the U.S. who are Hispanic. And that's, twice the size of Australia or larger than Canada, and even more Spanish-speaking heritage people in the U.S. than there are people in all of Spain. So it's a large group. And because we're a large group, remember how I said that thing about longevity? And I used to give speeches and say, if I were a researcher at NIH, I want to know why someone who is poor, less educated, working these crazy hours, overweight and diabetic is living longer than I am. Well, finally, after many years of working with the National Institutes of Health, they're doing a $61 million study to find this out, because they're finding that what they learn about the Hispanic population will help everyone else. Because, for example, also Hispanic women have lower rates of breast cancer. And this is, as you know, a major issue in the United States. And this is what Betsy Nabel, director, said. And we were very happy when she launched the study. 16,000 Hispanics over 6 years, really doing body measurements, trying to see what's going on. What are the challenges we have? I think the biggest challenge we have in anything in aging and immigration really has to do with where we are in understanding culture. Understanding culture is something which we struggle with in the U.S. This is a way of seeing people's understanding. You go from cultural destructiveness to cultural proficiency. In the U.S., very often people say, well, Jane, I'm colorblind, I don't care about any of this, and they think that's a good thing. That's not a good thing. It's not good to treat all people the same. Why? Because all people are not the same. You have to respect each individual, look at them, celebrate who they are, and work with that. Of course, being in the health sciences or social sciences, when you say that kind of thing, people think you're loosey-goosey, no one listens to you. Thank goodness that the Harvard Business Review published an article on cultural intelligence, because they really started to talk about that and how really understanding culture, understanding the patient where they're at was key to really knowing how to work with aging communities, with immigrants. And this quote I like because to me it gets at the heart of it. You will not disarm your foreign host simply by showing you understand their culture. Your actions must prove that you have entered their world. That's what cultural intelligence is about. These are some of the lessons we learned about cultural intelligence, cultural proficiency. The sensitivity training didn't work. Cultural competency didn't work because the least competent person always thought they were competent. But really, as we look to the future, we have to come up with new models. Now, a challenge in the US is communication. English is the dominant language, we all know that. Monolingualism is the norm. And you know, it's sad, it is the only country in the world where speaking another language is not valued. That makes it hard when you're dealing with immigrants and with other cultures and other people. There's also a lack of understanding of what it takes to learn to understand, to speak, or to write another language. Listening is a lost art. But more important, you know, as the head of a Hispanic organization, the least of what we do is translate for people. We adapt materials, we don't translate. And we say, yes, there is broadcast Spanish, and we can translate, adapt materials into that. But the concepts have to be adapted. Okay. Health is more than access, language, or income. We know even when we control for that, kids didn't always get the same treatment. And we know this in an emergency room where Hispanics were less likely to get a painkiller, looking at retrospective data, and disparities for Hispanics are increasing. All right, challenge. All consumers need accurate and timely information. Why is this important? Because in many ways, when you look at the 1899 Merck manual, at the time was like the place to go for science and information. This is what we were telling people then, that if you had asthma, you should take smoking tobacco, that was your medicine. If you had chest pains, you should take cocaine. And if you had diabetes, arthritis, and asthma, arsenic. And in fact, for us now, what we tell people is not too far from that. Okay, I'm moving. The next challenge is health and the environment, more than genes, the search for triggers. And I think we know about water pollution. This is changing everything, from telling mothers and older people, don't eat the tuna fish, you know, don't eat this, don't eat that. Environmental causes of asthma, we now know that trucks, air, very important. We have a program with 9 to 12-year-olds. This is some equipment we brought over from the UK so kids could monitor their air locally in Watsonville, Brownsville, Detroit, and New York, and that's what they're doing. This is the maps the kids are coming up with so they can see what are the toxins in their communities. And we also know that opening a window is not a good idea. I'm really done. I'm just kidding. I only have like 3 more slides. Opening a window is not a good idea. We have learned that, for example, in bad ozone days, people have more heart attacks. So don't go running outside if it's a bad air day. It's bad for you. And if you're an older person, don't go outside. It'll kill you. Challenge, we need new medicines. For example, gonorrhea is now one of the diseases for which we have very few treatments. So old diseases will come up as new disease as we have resistance to the treatments. So, as you look forward, this is what we used to do in the last century. Physical health, hospital-based health, you know, correlates, minority, acculturation, competency, one size fits all. And we were always going to avoid dying, you know, because somehow that was not part of health. When you look at your opportunities for the future, it'll be on all those things on the right, which is comprehensive health, home and community-based, health environment, defining triggers, tailored to the individual, cultural intelligence, personalized medicine, acknowledge death. That's also part of health. Thank you.